Welcome to the Owens Recovery Science Podcast. On today's installment, myself, Kyle Kimbrell, and Johnny Owens, owner, founder, president, really cool guy of Owens Recovery Science, we interview Dr. Mark Maniago. Dr. Maniago is a professor within the University of Colorado's physical therapy program, and he has particular research interests in persons with multiple sclerosis. So he dropped some knowledge on Johnny and I about how best to perform this in persons with multiple sclerosis, what their curiosities are from a research perspective, and he discusses their plans for the recent grant funding they received to look at resistance exercise with BFR in persons with multiple sclerosis. As always, if you have questions, curiosities, topics that you would like for us to cover on our podcast, shoot them our way at info@owensrecoveryscience.com and just put podcast question or hashtag podcast or something in the subject line or the first line of the email or something like that, and we'll get it and we'll take a peek at it and try to tackle that for you. So with no further ado, we'll kick it over to Jimmy McKay.
This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
All right, welcome back to another Owens Recovery Science Podcast. This is Johnny Owens here with the man on the wheels of steel, Kyle Kimbrell, rocking it out. And today we have a friend, an awesome guest, and something that we get a lot of questions about, and that is blood flow restriction with multiple sclerosis. This is Mark Maniago. Did I say it right, Mark?
Maniago.
Kyle's got it.
Maniago.
I grew up in West Texas, man. I mean, it gets a little bit cultural. I can't even pronounce it, man. So, Mark.
But Johnny's wife is Mexican.
I was going to say, you got to have like tons of Enyes around where you grew up.
Dude, you don't think I hear grief all the time from my mother-in-law, my daughters,
your wife. Is your wife from Mexico?
Her family is, like
nice,
third generation thing. But yeah, they're San Antonio, like serious, Latino.
Yeah.
Like she's already putting out Day of the Dead decorations right now. And so,
nice.
Yeah, but she understands that I'm an imbecile when it comes to
anything
like this.
I married into that myself, so
yeah. I'm goofy white guy syndrome. That's where I'm at. So anyways, Mark, let me just do your bio real quick, man. So you're assistant professor at the PT program at University of Colorado Medical Campus. You went from Chicago and then landed for your master's in Colorado, and it sounds like you never left. So you've been at University of Colorado ever since. You got your doctorate of physical therapy there, did your PhD there. And I don't freaking blame you. It's amazing out there. So if I could handle the cold and I could get my Latino wife to handle the cold, I would be out there all the time, but it doesn't happen. So, anyways, how we met and why you're on today is because you're kind of one of the leaders and someone who focuses on neurologic conditions and multiple sclerosis in particular. And so you've kind of, that's what your background is and what you do at the University of Colorado. I saw this too, man. You got the K-12 award for the CORT program, which is pretty cool.
Yeah, correct. So it's been a good year for grants, at least.
Yeah. Well,
nothing else is good this year. But
if you get one grant, man, that's amazing. But
I know. So
you've landed a couple. So the CORT, I don't know that well, but it's like Pitt, Delaware, WashU, right?
Yeah, those are the three core institutions: Pitt, Delaware, WashU, and then there's several kind of affiliated institutions. CU is one of them. Different PT and OT programs around the country. I don't know the total number, but so it's an internal K award. So they hold it at WashU, and then they have like an application pool from just the member institutions. So
yeah, basically the leaders in our academic world are all part of this, and you landed that. And then as well, you got the MS Consortium Center's grant for a blood flow restriction project with multiple sclerosis patients as well this year, right?
Yeah. So that was the one that just came through. So it's a pilot award from the Consortium of MS Centers, CMSC. And yeah, the project is to kind of look at the feasibility of BFR with resistance training, because I think we'll probably get into some of the literature that's out there that's done some other stuff.
Yeah.
And people with MS, and actually more specifically people with MS who have more mobility limitations and more what we call, I guess, like more advanced disability.
Yeah. And so we definitely are going to lean on you to get into the nitty gritty of what MS is and a lot of stuff we don't know. So very cool. And that last grant, you and I had kind of worked together a little bit. I was trying to do whatever I could to give you my basic insight into at least BFR, but congrats, man, on getting
Yeah,
that.
thanks so much. And yeah, I definitely appreciate you're absolutely right. All the help and input you gave. And we met at CSM and
So
had a couple drinks and talked BFR.
How this stuff always happens. CSM and drinks. I can't tell you how
I know. And that's what that's I think we're going to feel the effects of the pandemic.
Dude, I know.
On science in that way, because there's no like informal
I know.
conference drinking into the night where you that's where you get all the good ideas.
I mean, I think I lost like 3 or 4 studies next year doing a virtual CSM because there's no way we're not sitting. And we were day drinking, dude. Right? So
it was early. It was a little early. Yeah, it was lunch.
Yeah, it was lunch. Well, it was lunch, so it's fine.
It was probably a Friday, maybe Saturday.
And so I don't know, Kyle. So Mark and I met because Michael Bade. Also, we have the TKA trial going on at University of Colorado.
Yeah, Mike Body has right. So that's how even I got access to the equipment. So that's why
I'm so white. I screwed up Body. I couldn't.
Johnny is
BADE. I don't know that.
Johnny's good about goofing up.
Body's not a natural one for me on that one. So. He's from Wisconsin, so they're all backwards up there. Edit those up with that.
We edit that.
I'm a Chicago, so I'm a Bears fan.
Yeah. Oh, you're not a cheesehead. Yeah,
you guys are great last night.
Fan, so that's where that comes from. That comes from a Bears Packers place.
Nice.
Not anywhere else.
So Michael's got we have the TKA trial going on right now, the remote TKA trial with blood flow restriction, seeing if we can do this and monitor remotely with patients post TKA. And then he introduced me to you. We started drinking. Next thing you know, we're
funded.
We're older with this. We're funded, man. Let's do this. So anyways, man, if you want to fill anything else I'm missing on your background, but I kind of want us to get into multiple sclerosis, kind of what the disease is, what you're seeing from how you see it clinically. Because, what's cool about you is you're not only like faculty, but you work in a clinic as well to kind of help treat these patients. So I'm going to kind of let you roll, brother.
Yeah, sure. So, I mean, where do you want to start then? Do you want to start with...
Go over what multiple sclerosis is and
sure. So
we'll go into rehab.
Yeah. So MS is, obviously it's a neurologic condition, but the mechanism is primarily an autoimmune dysfunction. So it's a autoimmune inflammatory disease that attacks the central nervous system. So it can attack basically anywhere in the brain and spinal cord. It tends to be primarily in the brain and upper spinal cord. And it causes all kinds of awful problems and symptoms. So, demyelination, axonal loss, you name it. It creates these sclerotic plaques that form in the brain and spinal cord that are kind of the hallmark lesions that you'll see on an MRI. And really based on, where the lesions are, it can cause almost anything, right? Sensory problems, motor problems, spasticity, hypertonicity problems, sensory problems, cognitive problems, visual problems. So there's a whole wide variety of symptoms in MS, although most people have some sort of weakness and some sort of difficulty walking and with mobility. So that tends to be a lot of the target of rehab, and tends to be what studies show pretty consistently. That's what people tend to find most important are problems with walking and mobility, and want to focus on those areas too. So those.
And by people, you mean patients, Mark?
Patients with MS.
Yeah. Okay. Yeah. Or patients, clients, what have you? Whatever.
Yep. Exactly. So
use,
the other, I guess, kind of unique things about MS is it is it's a chronic / progressive disorder. So there's neurodegeneration that happens over time. Recently, there's been a lot of recently in the last maybe 5-10 years, a lot of breakthroughs in terms of what we call disease modifying therapies or drug therapies that have really helped to control relapses in the beginning of the disease. But it's still, considered a chronic / progressive condition. And then the other unique thing about it is that it affects mostly women, and then it also tends to affect mostly young adults. At least that's when the symptoms onset starts. So it's actually, I think, the most common like chronic or sort of progressive neurological condition in young adults. So that's kind of that's actually what got me really, I think, extra passionate about the condition is starting to see it clinically. We have a big MS center at the University of Colorado, and just being able to directly identify with people that are kind of going through the same, getting married, starting a family, all those kind of things, working full time, and then all of a sudden they got MS, and it just makes things obviously a lot more difficult. So
gets you down at your knees almost, man. Yeah.
Yeah. So, and then there's some geographic, I guess, markers.
I was actually going to ask this.
Yeah.
I was actually going to ask this because that's what I remember from school is that
it
it seemed like there was a higher incidence of people that lived in like northern communities, cooler climates, if you will.
Yeah, exactly. So there's still that association. They're still not exactly sure why. So no one really knows, what causes MS. It's probably some combination of genetics and environment and what's the third thing? Genetics, environment, and can't think of it. Oh boy.
I know.
There's like there's higher prevalence in the further away you get from the equator, essentially. So like Northern Europe, Northern United States, we kind of, Colorado kind of touches on that on the bottom of that latitude. Australia, New Zealand areas as well, Russia. And it's much less prevalent like around the equator in warmer climates. And so one of the big factors that might drive MS is vitamin D deficiency. And so that's maybe some of the thought is that just less overall sun exposure. Yeah. But again, there's lots of other factors like genetics. Smoking has been strongly associated with developing MS.
And a higher overall mortality for MS compared to general?
I don't know the numbers on mortality off the top of my head. It certainly can influence that, but I don't think there's a huge difference in overall lifespan when you have.
So primarily more disability driven then.
Exactly. I mean, quality of life certainly becomes lower, and there's lots of interesting research happening now about the interactions of aging in MS, but it doesn't necessarily. It's not a terminal illness by definition.
So the course of someone, say you're like 20, I remember my buddy, we were in college and he was diagnosed with MS, but he got arrested on 6th Street in Austin because they thought he was drunk. And the dude didn't even drink, right? It was one of those, he had his MS episode. Cops took him in and, yada, yada. He's doing pretty well. And I don't talk to him really that much anymore, but he would have a relapse, be okay, relapse, be okay. And so is that the typical course? Like you kind of are okay, then you get this, MS kind of episode, takes you down a bit, and then, 5th, 6th decade of life, you're kind of disabled?
Well, yeah, I mean, so that's the interesting part about it is that it can really vary. So some people could have a lot of relapses early on after they get diagnosed and have a really aggressive course. Some people have there's different subtypes of MS. So the most common being relapse remitting. So that's kind of what you're talking about. Some people have immediately what's called a progressive form of MS. And so that's a kind of a slower decline, but a steady decline over the decades and years. Again, before these newer disease modifying therapies had come out, the more typical course of MS would be kind of a, high, you start kind of normal level of function, you have your initial attack and you recover, 80, 90% of that. And then goes another few years and you have another attack and then you recover another 80, 90%. And then it's just kind of a slow decline. But the relapses, some people have them every year, some people have them every 10 years, some people have them every 20, 30 years. So that can really vary. Now with the new disease modifying treatments, they're really seeing a pretty meaningful and significant reduction in relapses. There's not the data to support that it's really, that we know in 20, 30 years, it really is improving people's lives. But a lot of the neurologists that I work with really kind of seem to think that's going to be the case when they get those data. So.
And so I know when you and I were first talking and working on this grant proposal, it sounds like you try and focus a little bit more on the severe MS categories.
Actually, no, this will be, my first study, at least, where I've only enrolled people with more advanced disability. So.
And how do you rate that? Where do you get that number from? Is there a scale?
Yeah, so there's the kind of the standard scale. It's called the Expanded Disability Status Scale. Mm-hmm. It goes from 0 to 10. 0 is no disability. 10 is actually death. And it's a variety. It's a clinical exam, so it's like a neurologist exam or a neurologic exam, plus some walking measures, and then you rate people on that scale. So it's like 0, and then it's in increments of 0.5 all the way to 10. And it's not really clearly defined where like severe disability comes in, but when you get to an EDSS, that's the abbreviation of 6, it means you need at least a cane to walk 100 meters.
Okay.
And so for a lot of us, that sort of is where we start considering people to be more advanced disability. So the current study is that'll be the minimum requirement, as people need a cane. And then we'll also enroll 6, 6.5, and then 7. And 7 is really, you're in a manual wheelchair really most of the day, propelling yourself. But you can get up independently and take at least a few steps.
Okay.
So that's kind of what the range we're looking at. And there's huge gaps in the literature about that level of that range of disability. So
that's a huge range for 1 point.
It is a huge, you're right. I mean, the scale it's a good example of where those like kind of categorical ordinal scales break down of like, it goes in really gradual increments of like, can walk 500 meters, can walk 400 meters, 3, and then all of a sudden it's like you're in a wheelchair.
Dead.
Yeah. Wheelchair dead. Yeah. Well, when he said 0 to 10 was nothing to dead, I went, that's a big.
Yeah, exactly. Yeah.
It's a big jump.
7 to 10 is like, confined to a wheelchair, bedridden, etc. So.
Well, when you're rating, 10 is probably the easiest rating of all time.
10 is easy. But if you're rating a 10 as a PT, it's not good.
Yeah.
That's a bad day in the clinic if you're doing
I never wanted 10 on any one of my studies.
No, that's why we did this, right? No 10s, no dead people.
Yeah.
So what's the standard rehab then? Or not, I'm sorry, I don't mean standard, but what do you think's like a nice rehab approach from what we see in the literature right now?
Well, there's pretty good guidelines, in terms of exercise, but they are pretty general. So there's guidelines that were developed, in 2012, 2013. We call them the Canadian guidelines because the Canadian, health ministry or physical, I don't know exactly, adopted them. And it was a Canadian group that researched them. And it was basically the result of like a really nicely done meta-analysis. And the recommendations for just sort of day-to-day physical activity are resistance training a couple times a week in major muscle groups, and aerobic training a couple times a week. And it's done.
I could have come up with that guideline.
Yeah, I know. At moderate intensity, so it's nothing, nothing too shocking. And then, where it gets much more difficult is everything beyond that. There's no standard, right? So you certainly want people to be participating in some sort of exercise on a regular basis, and we know that's going to be helpful for their everything, right? I mean, just like every condition. But again, like I was kind of alluding to in the beginning, there's so many areas where things can go wrong that it's hard to think there ever would be like a standard approach for for MS, right? Because you could have primarily vestibular imbalance problems and have no strength deficits, right? Or you could have all kinds of cerebellar kind of problems and coordination problems and very little strength problems or something. So it's difficult. And then, the other limitation, as I was kind of also alluding to, is those guidelines and all the research those guidelines were based on were basically everyone under a 6. It's not always clear what you do when people are in a wheelchair, for example.
What about the over-exacerbation of exercise and making their symptoms worse? I mean, is that...
Yeah, so that used to be a big kind of question mark. It's pretty well established that now, even at pretty high intensities, people tolerate. I mean, there's always going to be exceptions, but in general, people tolerate it pretty well. And you're not going to make... You might hurt them in, they might feel the hurt, right, for a few days, and maybe longer than someone without MS would feel the soreness and the fatigue, but you're not going to probably make the disease worse by overdoing it.
Not going to cause it to progress or
by
like
pushing
that.
it.
Well, you bring on an MS episode. So when I went to school, like in the dark ages, and so that was it. Like, with MS patient, I think our MS class was an hour. This is MS. You can make them worse.
Yeah.
They all need to do aquatic therapy. Keep them cool
and keep the pool cool. Don't hate the pool.
You're just like, oh my god,
that was it for sure.
I don't want to touch them. I'm gonna freak out.
So that's definitely, that was the prevailing worry for a long time. Now we're not. I mean, we're cautious, right? But we're not worried we're gonna set off an exacerbation.
Is it difficult to actually get a true diagnosis? So I had an Air Force colonel that had MS type symptoms. We actually did BFR on this guy, but he never really, he finally discharged and we never got a true diagnosis. It was kind of like he was, it could be sometimes a military thing. You're hesitant to throw diagnoses on people because there's this like disability thing. But it seemed like it was really hard for the neurologist to come to his, and I know neurological diseases are complicated. Is it MS the same?
If this was a while ago, it was the diagnostic criteria might have been a little, it was a little more difficult, I guess, to get that initial diagnosis. The diagnostic criteria, I don't know all the subtleties off the top of my head, but it's a dissemination of time and space. So you have to have essentially 2 distinct points in time where you had symptoms. And then also that needs to show up and be reflected on like an MRI or now. And so now that's been compressed a little bit where I believe they can look at an MRI and kind of, decide that you had a chronic lesion, now you have a new lesion, you reported symptoms in the past and now you're having symptoms again. So it's easier to get that diagnosis. They consider it now a spinal tap as well. So
that's what they did. So MRI, lesion based is really what you're looking at. I remember on him, it was spinal tap. They did an EMG. I think they did MRI as well.
Yeah,
But
it's a clinical diagnosis. Sorry.
Imaging's kind of the main thing for diagnosis.
Yeah, the MRI and then the spinal tap to detect it, and then the clinical symptoms. So that's a big part of it is what you detect on the exam, but also, if they report like, oh yeah, a few years ago actually, and this is pretty common, right? A few years ago I had my hands went numb for like a week and then it went away, or my vision was blurry for a week and then it went away. They're like, oh yeah, okay, that makes sense, and they put it together, and there's those 2 points, and then they make the diagnosis.
Okay, that's kind of what my curiosity, Mark, is. I mean, a lot of people that listen to our podcast are physical therapists, or at least in situations where people may just kind of come in from the community to them because they're having trouble with something. Is there, it sounds like from talking to you, there might be some distinct points in their life where they had some problems, some physical limitations, but are there, I don't want to say diagnostic criteria, but are there clinical pearls, things that might help someone pick up to say, maybe I should be looking beyond musculoskeletal here. Yeah, this might be
like clinical signs,
some kind of clinical kind of presentation that you would.
Yeah, I mean, absolutely. I mean, certainly anything, any upper motor neuron sign is going to be, could potentially, right? It could be a million things. That could be, something that would lead to at least a diagnosis of MS. Anything that's not kind of matching, right, in the standard kind of musculoskeletal exam, I think that kind of falls outside that could be explained by some sort of upper motor neuron lesion involvement. There are more common first symptoms. So vision loss, optic neuritis is one of the more common things that happens to people. So it's a change. It's not always a complete loss of vision, but it's a loss and change or change in vision. It's typically painful, inflammation of the optic nerve, and but it's transient. I mean, it recovers for the most part on its own. So sometimes that could be definitely a huge sign, right? That something else is going on. But yeah, I mean, that's what's so tricky about it. And that's the other piece that I think always attracted me to it is kind of the puzzle piece of it is, you could have also, numbness that might, I'm sure you guys know, right? Like they get the MRI and they have a disc and they have numbness in their leg. And so that's what it is. And so then they get the surgery and then they come to PT to rehab from that. And it's not getting better. And then all of a sudden they, leads them down the road to a neurologic diagnosis. So it's tricky for sure.
Sorry, man, I'm trying to get my Wi-Fi to work better all of a sudden.
I'm pulling up my medical lecture because I'm like, shit, I better.
That was good. Yeah, I know. I mean,
so let's go back this. So when we're day drinking in Colorado at CSM, what were your thoughts? I mean, I know, there's already preliminary, but when you're looking at BFR, were you looking at this from this is primarily a strength and hypertrophy, maybe helps with gait, or are there other things you were thinking, neuroprotection, hypoxic kind of stuff? So,
yeah, I mean, I guess when I first thought about it, I really went immediately to like what we were just talking about, the people with more advanced disability, right? So people that clinically, so a couple things, right? Like clinically getting them on and off like a leg press or them themselves, like trying to go to a gym and, do something like that, like mobility wise, right? Just really not feasible for them to do, or muscles that, sometimes they're active, right? They have against gravity motion, but the machines we have in the clinic, or, the means we have in the clinic are, they can't, push those weights or something. And then, doing those kinds of strengthening protocols and really trying to dose it well. And we do try to, be pretty precise with dosing with people with MS and progress them. appropriately, because that does make a difference, generally speaking. To do that with someone that's really weak and has a lot of mobility limitations is really tough. Like, trying to dose with different colored bands and tension and stuff. It just doesn't work that well. So I really saw like, wow, this modality could really help people. I saw a lot of potential in it in terms of people that have those mobility limitations and can only push low loads, being able to add that in and really get strength changes and hypertrophy and who knows? I mean, really that's what I'm interested in finding out is
the tip of the iceberg, I think.
Yeah, I mean, and that's why this is kind of framed as a feasibility study because who knows if people are even going to tolerate it, right? I mean, that's part of the big thing. We've done it a little bit in clinic.
You want to go over kind of like what you've done so far?
Yeah,
I know it's small, but I mean, just
I mean, COVID cut that short pretty quickly, but
COVID's cut everything short.
Yeah, but we've used it. I mean, really. In our clinic, with the equipment that you provided us, I've just had it on one person. So she is in what we would consider that EDSS of 6. So she needs assistance to walk, but she can walk, 100 meters at least. And it was amazing. First of all, she loved it. So she had a lot of, this was kind of an unexpected side effect, but she had a lot of neuropathic pain. Like that was one of her main symptoms. She's also weak.
Is that common?
It can be. Yeah. I mean, pain is actually another, area. If anyone's out there is thinking about doing some research in PhD and MS, pain and MS and neurologic conditions in general.
Well, we're doing a lot of work right now in
very understudied.
BFR. Yeah. But my Air Force Colonel guy, he had a lot of pain. That was actually his probably most debilitating.
Yeah. And it's kind of, it's really, talk about what you were saying, Kyle, like diagnosing maybe someone with a musculoskeletal, comes to your clinic with musculoskeletal problems, but has maybe a neurologic diagnosis. Well, someone with known MS that comes, they want to improve their walking, but they have all this pain in their back or their legs, and trying to determine where that comes from that's one of the hardest things that I do on a clinical, I think clinically on a regular.
And do you think that's the demyelination? It's like a neuropathic because
I mean, that's where I think it can be so tough because it can be primary, from the nerves. But then of course it can be like pain that any of us get just from overuse.
Overuse, yeah.
And then you also get really unnatural muscle imbalances, right? Just from selective weakness that then creates movement impairment, and then that creates pain. And so it can be really hard to distinguish one from the other, and then how do you correct it? And so it gets overlooked a lot and kind of pushed aside or treated with medication. So, so one of the first things that she said when she first had the occlusion was, "Oh my God, the pain in my leg is gone." And then we started talking more, and for whatever reason, this is not something I come across regularly with people who have MS, but she, I guess, commonly would like apply pressure, like really squeeze her legs, or she said she had her young daughter like sit on her legs to help relieve her pain. So she was like, I mean, this person she could be one of your spokespeople for BFR. She freaking loves it.
Too funny.
And so again, that's one person. But not only, so this was surprising to me because not only did she tolerate it, but she couldn't get enough of it. She wanted to come in more and more for it. Just not even, she didn't care about the strengthening as much. I mean, she did, but
she felt better.
Just the pressure. She found to give her relief, and so that was. I'd love to know if other people kind of have that experience. And
so interestingly enough, I just taught a course. We advertised this course as Tulsa, Oklahoma, but Technically, it was Okmulgee, Oklahoma, which is about 45 minutes south of Tulsa.
Okay.
Cool freaking town. It's like an old oil town, great like old buildings, and the place we did the course in is in this old building.
I'm from Texas. Nothing in Oklahoma is cool.
I know. I went to college in Oklahoma, but I'm from Texas. I'm with you. But just hear me out on this. So this is a really cool clinic. It's called Impact Rehab Wellness. The guy that owns it, his name's Michael Siegenthaler. He and his wife own it. His wife's
what up, Mike?
What up, Mike? He's a PT. She's an OT. So she had a patient that had chronic regional pain syndrome. They'd been working on her for, I forget her diet. Oh, she had, it was after a distal radius fracture. She had distal radius fracture, ended up with Crips. They've been trying all these different things, and she'd been coming for a while before they ever had a device to do BFR with. And Michael was like, why don't you just try this on her, just see. And the thing that they said was, as soon as they inflated the tourniquet and got that restriction, is her pain was gone. It was like completely gone. Mm-hmm. And the relief lasted for a while. They did some exercises, of course, and everything. But that was the hallmark, is they said the pain just like it went away, and it hadn't gone away forever. And there was some lasting relief. It wasn't like it, all came back, but it also wasn't like they repeatedly did this and it totally went away either. So it was kind of somewhere in the middle. But it was interesting to hear you say that, because I had a similar conversation just this weekend about that. So
yeah, and that's exactly what she would report too, is that it would give her relief that day. I don't remember exactly how long, but it wasn't, like you said, it wasn't like it cured it, but it was more than just the having it on.
It just makes you think there's something there. You just wonder what,
Yeah. I agree. I mean, that definitely made me wonder, because it was so dramatic of an effect for her, and it was so clear.
It's a big deal. You take somebody's pain away.
And I'd known this person for a long time, so I knew about that pain. And like I said, we had done a lot of clinical kind of exam on that and digging, and we eventually just came to the conclusion, this was years ago, because I've seen her off and on for I don't know, maybe 10 years, that, it's neuropathic pain. What's the medication?
Neurontin.
Neurontin kind of helps, so it does okay. We're just going to kind of ignore it and keep exercising. Is kind of where we were at with that. And then this really, affected it. So unfortunately, we weren't able to really do this long-term with her, just because we got cut short with COVID stuff. But she's actually going to be a consultant. I actually budgeted her into the study, so we'll pay her to consult in the study, and we'll also start kind of running through the protocol with her when, before we enroll people. So we'll make sure she gets.
Hey man, you didn't budget me in, and I mean, what?
Mark's like, edit that too.
No one ever budgets me in.
What happens is when you budget the person.
I'd rather you budget her in $1,000.
You run into all kinds of problems when you budget the person who provides the equipment.
Hey, man, I ride that line.
They don't like that, or I mean, yeah.
No, but this is a big deal. So I mean, we're really looking at this from the orthopedic side, and Luke Hughes, who's over, he's works close with us, has looked at endogenous opioid kind of upregulation from BFR. I don't know if that would help with an MS person or not, but Neurontin's a freaking nightmare.
It is.
And so we had so many problems with that with the service members in the DOD. I mean,
side effects of Neurontin.
Side effects, depression, weight, a service member that gets weight gain. It's just like, they get in this deeper funks. So, we were just trying to do whatever we could do to get off Neurontin. So, finding something to avoid these drugs like that, I think is huge. So that's super cool to hear. And hopefully, that's the thing we always we see these kind of like extras with this right now, so if you get this like analgesic benefit or pain, but then also it does increase strength and hypertrophy and increases function. That's just like, it's hard enough to get patients to come to rehab in general. But if you're like this person, I'm going to give you some pain relief. And if you do this long enough, you're going to get some strength and hypertrophy and maybe some functional changes. It's almost like kind of icing on the cake, which is pretty cool to me.
Yeah, absolutely. So yeah, it'll be interesting. Again, that was kind of her unique experience, right? So, um, and then she tolerated it super well for all the different strengthening exercises.
So do you remember I can't remember from the grant, your LOP you used on her was 60%? Her limit?
No, we went to 80 with her.
You did 80, okay.
Yeah, cool. So we'll target up to 80. And
lower extremity.
We
so go over, do you remember, just kind of go over what a session's like, just in case people are listening to this?
So we're going to target, and again, these are people that need assist to walk or even have trouble maybe with sit to stand and transfers and can barely walk at all. We're going to strengthen plantar flexors, ankle plantar flexors, I guess knee and hip extensors. We put it in the protocol, so like a leg press.
Leg press. Yeah.
And then hip abduction. So the hip abduction piece and really the ankle plantar flexion piece too come out of a lot of the work that I've done prior to this. That has found those muscles to be, and again, this is lower disability, so it might not generalize as well. But those muscles particularly to be really key drivers of at least walking in people with MS. So it's kind of that proximal stability and that power generation tend to kind of drive.
The calf is all that matters for gait.
Well, right. And the calf is really obviously all that matters for gait, but for MS also there's a lot of proximal weakness. And so, and I think we talked about this over CSM and drinks is it'd be just interesting to see also, proximal to the cuff. So we'll put the cuff on the lower extremity that, if we can have some hip abduction changes. So that's the protocol. And then the mode or the modality, well, I guess the modality would be the BFR, but the mode is I didn't want to use the traditional weight training machines because even this patient who could walk independently, our leg press in our gym is like 8 inches off the ground. And so getting her on and off that thing is a nightmare. And so someone coming out of a wheelchair, it would virtually be impossible. So we are going to use this little device called the shuttle mini shuttle press.
Yeah, the mini shuttle. Yeah.
Mini shuttle press. Yeah. So, and really it should be, it looks like it'll be enough. I mean, we've tried it, to dose most people because if you're doing, that low of a load, then that should be plenty of resistance. And actually with some of the stuff we piloted, like for her hip abduction, all she could tolerate was supine active range of motion. With the towel. Like, so she needed actually even a little bit of reduction of the friction that was there naturally. And just active range of motion. And she could barely get through those sets. So we're using that, 30, 15, 15, 15 dosage. And it was tough for her. So yeah, I think it'll be really cool. And then we're going to run into people who are also going to, probably not be able to move the ankle all that well. And so right now we're trying to figure out exactly what our protocol would be, for isometric or active, maybe even active assistive we might be doing for at least for the ankle. So it'll be interesting, I think, to see how it all plays out.
Yeah, I think we might have to look at isometric, potentially for at least that plantar flexor.
Yeah.
Yeah. Cool. So, all right, there's literature out there right now. And I'm going to use the term literature sparingly. when it comes to MS and BFR. So
one of them published right when I was submitting my grant. Got me nervous.
yeah, well, I think you're okay.
Yeah, they use quite a different approach. There's actually, can I talk about stuff that's about to be published? I think so.
Yeah.
So there's someone at Evan Cohn who's a PT and faculty member out at Rutgers. He's also a consultant. Sorry, Johnny. He's also a consultant on the grant. So he's been also playing with BFR and MS as well, and he has a case study that he has out in review right now. So that might be coming out soon. And his case study, his patient with MS did not tolerate it particularly well, but did tolerate it, but did not tolerate 80%, at least from what he told me. So I'm sure we'll get that, that whole range of response in terms of, what people tolerate and what they can do.
Sure.
But she was also, I think that person was also really high functioning. She was a runner and things like that. So it's a different, probably also pushing loads that were way higher than people in our study will do.
We see with a pro athlete, some of them don't tolerate.
Yeah. I was kind of a baby when I first tried it.
Yeah. So, tolerance is a different thing to everybody when it comes to this.
If your patient is really wanting to do BFR, you got to wonder if you're doing actual BFR.
Yeah.
Right. Yeah.
Unless they're getting something like if they're getting pain relief.
Different for sure.
Someone comes in like, I love this, let's do it. It's like, I'm not sure if I'm doing it.
Yeah, I did it myself for a couple of weeks, and it was, I never wanted to do it.
Yeah. People are always asking me like, I'm traveling. Do you just like do this in the hotel room all the time? I'm like, hell no. Hell no. It hurts.
It's awful.
I'll just go like work out or something. All right, man. So here's the kind of probably the main paper that's out right now. Effectiveness of blood flow restricted slow walking on mobility and severe MS, a pilot randomized trial. So it's out of Italy. It was in Scandinavian Journal of Medicine and Science 2020. It just came out this year. So I guess I'll just kind of go through this. So it was an N of 24. Their EDSS scale was a 5.5 to 6.5. They said severe.
So it's kind of that's where that sometimes there's not a clear cutoff. Sometimes people consider that 5.5 to be severe.
Okay.
But that's what the similar about this study, which I imagine they're thinking the same thing clinically, is like it makes more sense for people that have more
restriction.
Yeah, I think so. I mean, I think a lot of these disease type non-orthopedic populations, we have to kind of look at these higher disability targets. This Parkinson's study that we just did, it was with pretty severe Parkinson conditions, and they did really well. A lot of the other ones, it's like, yes, they can just exercise, but like you said, if you can barely get this person on a leg press, how are you going to be like, get them on a leg press and let's go for a 70% 1RM when I can hardly even get you into the chair? So.
And I think the other call for neuro, just to not to diverge too much, but the other call in general for neurologic therapy is like, we got to think about our dosing. And I think a lot of times we don't think about our dosing that much. And we're happy just to like give them the yellow TheraBand and then the red one, and then kind of like estimate, roughly at, I don't know what, right, 15 reps or something. And so I think that's the other really appealing part of this, especially from the scientist side of me, is like, can we really get pretty specific about, inclusion and dosing?
Yeah, I think BFR, it becomes so standardized. That's what I love about it as well. It's like, how much was your occlusion pressure? We did this specific set and rep scheme, and what was your dosing? It kind of lines you up where you're not like, here's yellow TheraBand, do 3 of 15, and you're just doing glorified range of motion.
Exactly.
Which is wasting your poor patient's time, and giving them like false hopes. So, Yeah, the standardization.
I think that the dosage is a piece that's just lost too much in our profession, and whether it be musculoskeletal or
Not just
neuro, 'cause
neurologic.
it's not
Right,
it's
yeah, I
it's
mean,
not like muscle magically responds to a lower stimulus when you have a neurologic condition. You know,
Yeah.
it's still muscle. We know what you have to do to muscle to get it to change.
Yeah.
It's our job to figure out how to do that to muscle, but we got to know what to do in order to be able to do it. So
yeah.
All right. So back on this study.
The study did not do resistance training.
yeah.
So this study, again, probably the first real MS BFR study we have. 24 subjects, 12 and 12. So 12 in control, 12 in the BFR group. Here's starts to get into our problems with this study. So they did it 2 times a week for 6 weeks, which is just, that's fine. That's a good kind of protocol. So 12 visits, but then their occlusion was 30% of systolic blood pressure on the lower extremity. So they took BP on the upper extremity, and then they did 30% of systolic blood pressure, which basically they just did a sham intervention. That's like 30. If you're at 130 systolic blood pressure, that's 39 millimeters of mercury of occlusion. Most of our sham protocols are 50 millimeters of occlusion and under. So already when you read this, you're like, you basically did a sham protocol. I think they were maybe nervous.
It would make sense. Yeah.
So, I mean, as soon as I read that, I was like, this was almost zero occlusion at all. And I think where you can tell that is, when they looked at the BFR group compared to the control group, rating and perceived exertion was harder in the control group than the BFR group. If anyone's ever done BFR ever in their life, right? It's going to be way harder than a low level stimulus. And also heart rate didn't increase in the BFR group. The control group did. So if you're occluding an artery with blood flow restriction, heart rate's going to automatically go up from the exercise pressor reflex. Right. Or if you're blocking venous return, stroke volume goes down, heart rate's going to go up. So when you start to see hemodynamics aren't changing, you're already questioning, like, you're not really occluding, I don't think. So RPE didn't change. Hemodynamics didn't change. They use this thing called an occlusion cuff, which I know it's a pump-up-y one. So we know those don't even hold pressure. They're thin. So 39 millimeters of mercury on an occlusion cuff is basically zero occlusion on your vessels. They even put a note in there that they would have to put it back on and re-pump it up to try and get it. Yeah. So fatal flaws already off the bat. And then their design was really wrong, I think. And I don't know why people just don't do work matched. I mean, why would you have a control be so different than the BFR group? So the BFR group did 1 minute on walking, then they deflated the cuff for a minute, and they did that for 3 times. And they did that for 5 bouts. So they did 15 total minutes of walking. And so they were doing this interval kind of walking. And the control group, they just said, walk straight for 40 minutes. Yeah. Right. Completely different volumes between the 2 groups.
They had more rest in the BFR group than they did actual rest work time.
In the BFR group,
what 22 minutes of rest, 15 minutes of work time.
if after a week they were able to complete that 1 minute interval, they would tell them to walk faster the next week. So they added 3 more feet to their, so they had them work on walking faster. So interval, almost like sprints, they were having the BFR group do. In the control group, they just did 40 minutes. And so the results were this: the BFR group only walked about 435 meters compared to the control group, who would walk about 855 meters. The standard deviation in the control group alone was 478 meters. So the standard deviation was more than what the BFR group walked. So the control group walked steady state a ton more. The BFR group was just doing these like kind of fast sprint interval kind of walks. So the BFR group had a smaller increase in heart rate. That's a problem. BFR should never have a smaller increase in heart rate. And they had a lower RPE. That's a problem. BFR people should never have a lower RPE than just a control. And at the end of the day, they said that the control group had a slower increase in their walking speed. So gait speed increased in the BFR group, but it didn't increase in the control group. The BFR group, all they did was work on increasing their gait speed. Little 1 minute fast walks, 1 minute fast walks, 1 minute fast walks each week, increase a little bit. The control group just walked 40 minutes, for steady state the entire intervention. And then the discussion even said, it looks like interval walking is better for people with MS. In a randomized crossover trial, subjects with MS walked further and with less fatigue when walking intermittently compared to continuously uninterrupted. So in my mind, I think this is a throwaway study to me. Minimal to zero occlusion. The one group got faster their walking, but they trained them to walk faster, doing these quick little minute interval like walks compared to the control group that just did long 40-minute walks. And they didn't say when they retested them. So if the control group's walking basically a mile at a time, the BFR interval groups, walking less than a quarter of a mile, and then you retest them a day or two after the 6 weeks, the control group's probably a little bit of a beat down group compared to the BFR group. That was my takeaway. I hadn't read the study fully until this weekend, but what do you guys think of that one?
Yeah, I mean, there basically wasn't any differences, right? So the between group comparisons were all non-significant. So, and it's not surprising, like you said, looking at the intensity of the control group and what they did compared to the intervention group. And I would speculate exactly what you're saying is that really, I think they probably were more interested in, hey, is this going to be safe?
Yeah.
And feasible? And I think I understand if that's what their kind of, I think, bottom line question was. I understand as a researcher the difficulty of that question, right? Because if you're interested in safety and feasibility, which is the kind of the main aim of our award, everyone's going to get the BFR. There's no control group, and that's a big limitation, especially when you go to publish it. But ultimately, you want to get as many people through as you can to see who tolerates it and who doesn't. And so I think you sacrifice some of that stuff when you do these small randomized control trials where you underdose and really underpower. I mean, even if they had dosed it more aggressively and done more inclusion with 12 people, you might not have any differences anyway.
No, it's definitely a pilot. Part of doing research though is you have to be a little bit risky to test your hypothesis. I would really say they did nothing from an occlusion standpoint in this study. A narrow pump up cuff at probably under 40 millimeters of mercury. That's a sham treatment. So, if I reviewed this paper, I would have destroyed it. Seriously. And this, one of the authors on this has a similar paper where they showed nothing happened. He did this other cuff, this B Strong one, and showed it did nothing different than low level exercise. No increase in lactate, no increase in hemodynamics, no increase in RPE. And his final conclusion was, well, it's safer than a wide surgical cuff. Well, hell yeah. You sure it is, because it's doing nothing, So it's straightforward. So these kind of things drive me crazy.
This is the problem for me. I don't look at the study and think it was designed to determine safety and feasibility. Like when you look at they say that that's what it was, but I'm like, well, how are you determining that? Just the fact that there weren't adverse events. Same with the B Strong stuff. They made those statements about it looks like it's safer and more feasible, but it's like, well, that's not how you design the trial. Like you need to design the trial to show that, which it sounds like, Mark, you have. Everybody's going to go through this. We're really kind of looking like, is this tolerated? Is this feasible? Done. That's what you're looking at. You can't just make these other conclusions based upon, we also measured RPE. We also did this. They were looking at.
That's definitely our aim. Our primary aim is all about the feasibility from the user standpoint and the safety. So, And so that's why you scientifically, I think, design a trial like, you put everyone through the intervention because, or you do maybe a crossover, right? So you want to get as many people touching that intervention as you can.
Yep.
Right.
Or else you don't know, right? Or you know less than you could have, right? If you randomize them or don't give them that intervention. And I agree. I mean, you want to try to, well, I think with BFR it's relatively easy, right? You know what you should be shooting for the most part. And so you try to be as aggressive as you can. And then you can always back off, right? But so.
All right, so Mark, we can throw that one out. You're already one step ahead.
One of those guys is from Texas, actually.
Yeah. That's the guy who had the other paper.
Okay.
Yeah. That B strong one that showed nothing. But there's another one though. It's not a BFR, but it's ischemic preconditioning or remote ischemic preconditioning. So I don't know if you read this one, Mark.
I did. You sent it to me a while back, and I that was totally. I mean, like I said, all this is new to me, but that was even.
Is that
newer.
the British Medical Journal one you're talking about, Johnny?
BMJ, yeah. So it's BMJ neurology.
It's interesting. I thought.
Yeah, this one was actually good. So this is out of Sheffield, in the United Kingdom, and so larger numbers, 75. And so what they did was they had the controls do a sham. So their sham basically was 30 millimeters below diastolic blood pressure. So you're saying about 50 millimeters of mercury. So basically what the other group called an intervention, these people are calling their sham treatment, which most of us say 50 millimeters of mercury is a sham when we set up sham trials. I've got a couple sham trials going on right now. And then the other group, so we don't love this method of blood pressure, but if you do blood pressure on the arm, it's a better marker for limb occlusion pressure than it's not valid in the leg. So they did blood pressure in the arm, and then they put a BP cuff, or they put a cuff on at 30 millimeters of mercury above systolic blood pressure. And the typical kind of RIPC protocol is 5 on, 5 off for 3 rounds. That's pretty much what all of us are using. And it was a double-blind randomized trial. So the patients were blinded, the testers were blinded. And primarily they were seeing, could you get improvements in a 6-minute walk test if prior to walking, you put these cuffs on. You put it on and you did full ischemia. So remote ischemic precondition means you're trying to get 100% of occlusion, or you did a sham treatment. Could MS patients walk a 6-minute walk test further? And what they found was they did see an improvement. So the remote ischemic preconditioning group increased their walking time by 5.7% compared to 1.9%. It's statistically significant compared to what the sham group did. Discomfort was definitely worse in the RPC. Again, that's what you should see, 0.001. So it was definitely harder, but they did increase their walking distance just by putting the limb into hypoxia prior. And the group in the intervention had worse ratings of MS compared to the sham group. So they actually had kind of a worse group from the baseline data and improved it. So that's kind of fascinating as well. This kind of hypoxia, remote ischemic preconditioning increase 6-minute walk time significantly in this group. In BMJ, I think it's a pretty well done study. And that's another kind of interesting way to maybe approach this. If your patient can't do leg press or calf press or something like this, there might be this hypoxic event you should put them in. And there's a really good editorial in Frontiers in Physiology. Camara, Lemeroy, I don't know any of these authors on this one, but basically expanding the potential therapeutic options for RIPC using it in multiple sclerosis. And they really go into the neurologic kind of protective effects, the fact that MS is kind of this chronic hypoxia thing that goes on in the brain and these acute hypoxic bouts. seem to elicit all the things that you would see your body trying to do to fight MS, like release HIF1A and stuff like that. So it's kind of fascinating because that's a deep commentary. I mean, you got to read it like 8 times to really understand what the hell they're talking about. But it's really going into this gene expression that they think hypoxia does with MS patients.
Huh. I haven't seen that one. I'd love to see that one.
Yeah, it's open access, Frontiers in Physiology.
This article is really well done.
Yeah.
And the effects are really marked and look really important. I mean, the only argument that against the patients in the RIPC group were more advanced disability. So only knock I could have is maybe they have more of a window to improve because they
right.
Versus, so I have to relook at what the baseline 6-minute walk scores were, but and of course anytime you're comparing unequal groups it's kind of an issue, but but I agree it's really interesting and promising.
Yeah, and I think that's something we can look at these severely disabled people is just the gene expression we get from hypoxia or something. When they can almost not exercise at all, can we as therapists use hypoxia as this new modality? I mean, we talked about it. The Nobel Prize in Physiology last year was about hypoxia and how it manipulates gene expression, and that Frontiers in Physiology commentary just goes into all the organ protective effects we see from this. And so I definitely think that's a very cool kind of alternative route to go after. Because again, I would love to see the 6 and over people have an alternative where it might be almost impossible from a therapist standpoint. Like, what can I do with this person?
Right.
It's like, maybe we have to start working on gene expression.
Yeah, I mean, there's so much that intersects there. I mean, in terms of like, one, I mean, clinically, you kind of, once someone comes in, they've been in a power wheelchair for years and they haven't moved, you have no hope that you're going to get them up and moving again.
Yeah.
I mean, you want to maximize their quality of life and you shift to that whole kind of other model of, prevention and compensation. But to think about remediating there is not anything that anyone's ever considering, I don't think. So that one is just amazing. And then also, like you're just saying, like, and I don't think I've really considered this before, but the idea, where rehab overlaps and kind of intersects with gene expression and genetics, and that's, I don't think otherwise really, I know like on, CAPD criteria and stuff, they want us considering genetics and those types of things, but I don't think that was I don't think that had in mind the idea that we could do something that would affect it, right? It'd be more like, hey, we'll consider someone's genetics when we're going into this, but.
Well, and that's the thing, it's like, okay, we're always with rehab, like we're going to do this many sets of whatever with a yellow band because we're trying to increase treated hypertrophy and we're doing nothing. But the Nobel Prize guys stuff was like, if you put a cell in hypoxia or you put a limb in hypoxia, you can create angiogenesis. So maybe your treatment from rehab is like, you need to come in, I need to put you in hypoxia for weeks to get an angiogenic response. And I'm working on a grant tomorrow morning. We see this expression of stem cells, not only from the muscle side, but also from the bone side. And so if we're getting this upregulation of all these kind of growth factors from this hypoxic event, I think we might have to look at how we can use this on our side and say, we're trying to build this person up to baseline. There's Chris Fry, who's a brilliant physiologist, who's someone we work with quite a bit. He showed that elderly individuals, part of the downside to them putting on muscle is their low level of capillary density. And if you can increase capillary density, their baseline level increases so they can start to actually put on some muscle. And you increase capillary density, you can by hypoxia. It's
Yeah.
it's undeniable. It's been put out in the highest tier journals by some of the brightest people out there. So, for an MS patient, if they're doing this and you're increasing their capillary density, you've already maybe given them this baseline level that they can just keep going more and more and more.
They can build off of. Right?
Yeah.
That's super interesting. And it's, it's what's really gotten me more excited about this is, kind of coming at it from, this is like another tool I could use in my clinic to help people that have more advanced disability get a little stronger, and just make it more feasible, to thinking about all the sort of the potential of it. And it's pretty cool.
You know what we need, man? More day drinking. We'll figure this out.
Well, it was daytime here till about a minute ago. So
I just need an invite next time. I didn't get the invite this last time.
Where were you, man?
I was working the booth.
Oh,
I was doing.
That was on Body too. I think Body treated us for that one.
Did he? Good on Body, man. The silver fox. All right. Well, good, man. This was super fun and super interesting. Yeah. I think a lot of people are getting a lot from this, and thanks for what you do, brother. This is super.
Yeah, cool. I hope I didn't screw too much up about MS diagnosis. We'll see all the time.
More than we know.
Yeah, well, yeah.
I remember the demyelination of the optic nerve from school. And
optic neuritis.
I remember that, and I feel like there was something in there about erythrocyte sedimentation rates and that kind of thing, but I might have that mixed up. But at least back in the day, that was a while ago. School. So
the other thing that's cool about this trial that made me remember, because I did read this when you said this to me a while ago, is like how many interventions in rehab can you do double blind? Placebo-controlled trials, none, right? I mean,
right.
And so to be able to do something like that, it just puts you in a whole nother level of science, right? So,
there's a ton of potential.
Yeah.
And you've got a lot of literature backing you up, and a lot of smart people and good labs that are kind of backing up the basic science of what we're doing here.
Yeah. So if you have a few more minutes, I'd love to chat a little more.
Yep. Well, let me close it up. So, Kyle, do you do anything closing here?
Nah. All right. We can just say peace out.
All right, Mark, man. This is good, brother. Thanks so much for coming on.
Yeah, this is a lot of fun. I'm glad we all got together.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.